I think it's time for the next session, which is again very interesting session. We'll have four very good talks. And the session is on thoracic and gastrointestinal tumors. And to start the session, I would like to invite the chairpersons. Dr. J.P. Agarwal is the professor and head of the Department of Radiation Oncology at the Tata Memorial Hospital. Good morning, sir. Welcome to the meeting.
Good morning. Good morning, everybody.
Dr. V. Kannan, head and senior consultant at Hinduja Hospital, Mumbai. Welcome, Dr. Kannan. And Professor Dr. Subramani at Medical Physics. He's a head of Medical Physics in All India Institute of Medical Sciences, New Delhi. Welcome, Dr. Subramani.
Good morning to everyone. Good morning to everyone.
So over to you.
Dr. Agarwal.
Yeah, all good. So, thank you, everybody. And I think it's quite interesting. The legacy of the practicums are going on, and it's good, at the sense that we can understand the final nuances of the whole system. Srinivas, shall I start to introduce, or Dr. Kannan has to say a few words and then Subramani has to say some few words?
Thank you, Dr. Agarwal. Yeah. Thank you. The interesting thing about this session, I feel, is primarily thorax and GI or movement-based therapies we have to adapt, and this is the area we want. The surgeon says we see and treat. Like that, for the radiation oncologists say we see and treat. We see a non-moving thing in a brain perfectly okay, but how is it going to be in thorax and abdomen? This session in that way is going to be very interesting, both from a photon point of view and from a proton point of view. Yes, we are very eagerly waiting for the further continuation of this session and waiting for the experts to come and discuss on this. Subramani.
Thank you, sir. I think thanks for the opportunity. I think we can move forward for the sessions. We can invite the speakers. Yeah.
JP sir, can you invite the first speaker and start the session, please? Thank you.
The first speaker is Dr. Patro. He's a chief medical physicist and he has done his PhD from the MIT University and he has been trained at Miami Cancer Center, and he is really a master of the motion. We look forward to learn from Dr. Patro. Welcome, Dr. Patro.
Thank you, speakers, and thank you giving me the opportunity to speak about motion management. Okay, as Dr. Kannan said rightly, the main problem with thoracoabdominal cases are the motion. Okay, so my presentation will having this introduction, some challenges, what is the motion mitigation technique that we use in APCC, followed by points to remember. So, as we know, the aim of radiotherapy is just to kill the cell, not the man. Okay. When you put the motion on that man, then it is like you become a Arjuna and aiming the face by the reflection. Means you cannot see the tumor, but you are seeing a reflection, and on behalf of that reflection, you are treating the tumor. Okay. So being a Arjuna, so what are the problems? It starts from intrafraction motion is a main important issue in a thoracoabdominal cases, and this motion comes in skeletal, muscular, this cardiac and gastrointestinal, and this will result in tissue motion, transient deformations and density variation in the patient. So this motion effect is almost all tumors that comes in a thoracoabdominal site. And this has been extensively studied and extensively discussed in photon era, and to how to mitigate this motion. Either it will be with internal target volume or mid position or shallow breathing, or using a compression and suppressing the motion, or otherwise you are going for a gating, tracking, or whatever else is applicable. And it is very widely described and discussed in APM report 76. So can we extrapolate this motion mitigation in photon therapy to the proton directly? You can say yes, someone can say no, or someone can say maybe. So a small part can be yes, no in small parts, and it may be in few cases. So what are the challenges with proton therapy? In last few sessions, we have discussed proton therapy is a very good tool to treat the tumor at the same time sparing all the organs nearby extensively, and it is far better than photon with clinical, dosimetrically as well as clinically. If we come to proton, as we know, proton delivery can be done either in a double scattering or pencil beam scanning. I will come to the pencil beam scanning. Pencil beam scanning delivery system is delivering spot by spot, followed by layer, followed by covering the whole target. Okay. So when you check the dosimetric superiority of proton with respect to photon, it is well documented and well published everywhere. Proton will give a far better dosimetric results in lung cases, or in liver cases, or in GI cases, or you come to say all these thoraco-abdominal cases. But where is the problem? As we know, with motion, there is a deformation of the tissue, deformation, motion of the target, and there is a change in hospital unit. So, in the left side, you have this nominal plan, but when you come to right side, is the actual dose delivery with respect to motion. You can see because of change in the what you call the HU unit or the density, there is a change in the dose delivery. Okay, or absolute dose. And it's not like that due to the motion of the target only, it's due to the motion of the adjacent organs. Okay, if suppose this is the target, we have to this is the target and we have to target it from the right lateral side, then it will pass through the diaphragm. And it is very well, you can see over there, the diaphragm is moving and it will result in a change in the water equivalent path length, and we know it is very much sensitive change in the water equivalent path length. So we have to mitigate this to get a desirable dose distribution. So if at all we will say for a pencil beam scanning, the problem occurs due to this interflow effect. This is the original dose which is delivering the whole dose. Sorry. Okay, but when you integrate with respect to motion, there will be a hot and cold spot appearing because of the change in the density or change or deformation in the target, what you call the OARs and everything, and it will present a dose blurring. So there are multiple conscious guidelines that have been published, and they have recommended how to mitigate this type of motion in proton therapy. And recently, AAPM task group report 290 has come, which described extensively about respiratory motion management for particle therapy, for pencil beam scanning therapy as well. So apart from that, there are n number of publications they have shown that we can effectively implement pencil beam scanning therapy in a moving tumor. So what are the challenges? Challenges starting from selection of the patient to simulation to image acquisition to treatment delivery and treatment planning. So I will not go through the selection of patient or clinical site. I will stick to the technical part of the technical challenges in implementing pencil beam scanning in proton therapy. So challenges with simulation. First and foremost, we have to evaluate the motion with a proper imaging. Then we will select the appropriate motion mitigation technique like free breathing, deep inspiratory breath hold, compression belt, gating, tracking, any one of above or a multiple or combination of any one of the aboves. Okay. Coming to image acquisition, this image acquisition is dependent on the motion, speed of the motion of the organ. Also, with respect to the speed, that there will be a deformation in the imaging. So, and we know okay, all these GI structures and thoracoabdominal structures move a lot, and there are published literature okay, the superior inferior motion can be as high as 20 mm in lower abdomen, and in pancreas, if it is a shallow breathing, it can go up to 25 millimeter to it can go up to 55 millimeter if you go for a deep breathing. Okay, and it's not about the motion, it's about the location. This motion is dependent on the location of the target, location of the organs. So this resultant motion can be quantified with the help of a cine imaging like fluoro or cine imaging. But the problem is it is a 2D in nature, and this can quantify only the superior, inferior, lateral or your vertical motions. But in proton therapy, we know if there is a deformation in the organ, that will perturb the dose. So we need to know all the 3D data, and that can be acquired with the help of 4D CT, which is 3D in nature, and it also gives the absolute movement and evaluate the organ deformation. Okay, then coming to challenge in the simulation, as I told, we can use any 4 of these: free breathing, deep inspiratory, compression belt, or getting tracking. So most of the things, for breathing, compression belt and tracking, we have to evaluate the 4D CT, be in the 10 phases, acquire the average CT, MIP or mean IP for our contouring as well as planning. If we are going for deep inspiratory breath hold, we have to coach the patient, which is foremost requirement for treating a pencil beam therapy with deep inspiratory breath hold. Okay, and we have to acquire multiple images to know the reproducibility of the breathing, deep inspiratory breath hold. Then coming to planning, you have to use SFO, which is very much robust, we know that, and optimization, robust optimization along with Monte Carlo algorithm. For free breathing, we may use layer repainting or volume repainting to minimize the blurring effect. And for deep inspiratory breath hold, it is straightforward SFO robust optimization plans. Okay, then challenging with the plan evaluation. So we have planned, but what is the actual dose in all the phases? So we have to evaluate in all the phases or all the images that we have acquired during the simulations, and it should be covering the target in all the phases. Okay. Apart from that, there are 2 denominations like 4-dimensional dose, which is nothing but is the dose is evenly distributed among all the phases of the 4D CT and calculate the resultant dose. So we are including the motion in our 3D planning, and it remains, we assume that it will be remain same for all fractions of the treatment. The other way is the dynamic 4-dimensional dose. In this, we assume the patient respiratory as well as delivery timing information will change with respect to spot delivery time, interspot time, layer switching time. And if we include all these parameters in our breathing technique, then we call this dynamic 4-dimensional dose. This can be done prospectively as well as retrospectively to know what is the resultant dose has been delivered or going to be delivered to the patient. Then coming to the treatment delivery, and it's a big challenge how you want to deliver whatever you have planned. So it is different for different, like free breathing, we have image guidance, we have to see the daily CBCT, then monitoring the patient, and 4D QA 4D CT, means multiple 4D CTs are required subsequent treatment time. Okay. Then coming to deep inspiratory breath hold, same image guidance followed by triggering of the beam, so that if there is a less deep breath or breathing is not accurate, then it can trigger the beam. So there are the few different type of DIVS techniques like SDRT system, ABC system or SDX system can be effectively used in a thoracoabdominal cases for deep inspiratory breath hold. Or we can use different vendors are there to provide the compression systems that can be used effectively in proton vault. So is this much is the sufficient? No, there are more challenges, because during the course of the treatment, there is a change in motion pattern in the patient, because of the radiation, or deformation happens in the organ itself during the course of radiation, or you can have a case of regression of the target or some type of inflammation in case of lung cases. Then we have to adopt the plan. So these are the most of the challenges that we may come across while implementing a motion management in proton therapy systems. So in APCC, as Dr. Daya discussed yesterday, we in our first year of clinical, we have implemented our motion mitigation technique. So before going to motion mitigation technique, all the technical reports or the PGs have mentioned you should know your system. You should evaluate your system and find out what is the minimum motion that you can treat with appropriate motion management. So we have used CIRS 4D Phantom, which can replicate the motion in all 3 directions. So we have simulated the worst condition for our measurement. We performed for 3 different motions, like starting from 5 millimeter to 10 millimeter to 15 millimeter, to find out what are the effect happening due to the motion on the dose delivery. This fluence was captured with the help of a graphomic film and calculated gamma comparing with respect to the plant beam. And we have observed, lesser the motion, better the gamma values. Means lesser the motion, the delivery is much better, which is already published in n number of publications. And increase in volume reprinting increases the gamma passing. So in case of free breathing, you can use some sort of repainting. Either it will be a volume reprinting or layer repainting to mitigate this motion in a very small motion, if there is a very small motion. So what we do in APCC, if we have a patient in a thoraco-abdominal lesion, we first evaluate the 4D CT. If the motion is less than 5 millimeter, we directly go to the free breathing treatment. And if the motion is more than 5 millimeter, then we have an option of either we go for a deep inspiratory breath hold or compression belt. So we always start with deep inspiratory breath hold, because this will minimize the motion starting from 20 millimeter to come to almost 3 to 5 millimeters. Okay, but there is a condition. To do a deep inspiratory breath hold, the patient has to do the breath hold continuously for a minimum of 20 seconds. This 20 seconds we have evaluated with respect to our imaging time, because the on-board imaging can be done minimum 30 seconds takes to take the CVCT. So it requires minimum 2 breath holds to get the CVCT done. And the most important is the reproducibility. Okay, so the deep breath hold should be reproducible subsequently, not for the same day, for the multiple subsequent days. Okay, if it is coming in our condition, then we go ahead with the DIBH and we go ahead with the treatment. If the patient is unable to do this, then we straight away go for the compression belt, which is the last option that we are having. So again, if we are using a compression belt, if the motion comes down to 7 to 8 mm, then we will go for the treatment of proton therapy. Otherwise, we say no PT from our physics point of view. Because with respect to our measurement, we say 7 to 8 mm is safe enough. There are literature we suggested up to 1 centimeter we can do with free breathing, but we are little bit of conservative with respect to that. So to acquire the 4D CT in our system, we have a Canon Aculen LB along with GATE CT from LNRT. To acquire 4D CT, this is the first Aculen LV with the GATE CT LNRT in India. So we have had a long problem with respect to taking out the SOP, how to get the 4D CT done with these systems. Then with respect to delivery system, we have a IBA Procteus 235 PBS system along with LNRT SGRT system for motion management. So for free breathe at APCC, we always acquire 4D CT, as I told you, contour the target in average CT, and we do the proton planning in average CT. we always override the density for IGTV or ICTV as per requirement, as it has been mentioned in all the TG reports. We always try to perform the SFO plan, which is the robust planning system. Then we do robust optimization with respect to setup, and we always take 5 millimeter and 3.5% of range uncertainty along with Monte Carlo algorithm we already discussed. And we use multiple field arrangement. Multiple field arrangement again take care of this rescanning if we go for a SFO planning, and evaluate this nominal plan in all the setup and range uncertainty along with all the 10 phases of 4DCT to know how the dose distribution. As per the patient positioning is done with the help of CBCT, monitoring was done with the help of LINRT system. We do periodic QACT or QA4DCT as per requirement, and the QACT triggered by the CBCT in our institution. Adaptation of the plan we do as per our requirement, as per the patient requirement or dose perturbation. DIBs at FECC has told coaching of the patient for breath hold for minimum 20 seconds, consecutive 12 to 15 times. We do this coaching rigorously for 2 to 3 days. Reproducibility was checked for minimum of 2 days to see, you can see over this that this reproducibility is within 2 millimeter. Contouring and targets are done in a DIBS CT. We do SOPO planning, robust optimization as we do previously, multiple field arrangement, and evaluate this robust for setup and range along with all the multiple DIBH cities. For the DIBH implementation, patient setup was performed with the breath hold condition. CBCT is acquired in the breath hold condition, acquired the reference image SGRT, then we monitor with respect to SGRT system that you can see over here. When the patient takes a deep breath and holds and it comes into our required range, then the treatment will be on, otherwise it will be triggered by the SGRT system. And we also give the feedback system to the patient for better reproducibility of the deep inspiration. For compression belt, we evaluate the efficacy of the compression belt by taking 4DCT. For compression belt also, you need to have this 4DCT because we know 4DCT is very much requirement for proton planning. Okay, contouring and target is same as like free breathing and density override, and we do SFO planning and evaluate this plan for all 10 phases along with the setup and range uncertainties. And we evaluate with respect to CBCT. You can see over here the reproducibility was perfectly okay with compression belt. So it required the patient patient cooperation. So motion management, I can say by seeing these slides, motion management is like a baby. Anyone want to have it because it's very, very helpful, means it's very cute and very this thing. But till it starts crying. The moment it starts crying, it will make you on your toes to make that stop. Otherwise, they will not help you out. So we have a lot of challenges in day-to-day treatment. Like in lung cases, we have seen within the first week, there is an inflammation and that has put up the dose enormously. So we have to do the replan or adaptive plan in the first week itself. This is not the end. After 2 weeks, it has come back reduced drastically. So by reducing, we got, the coverage was perfect, but we are getting a very hot spot in the esophagus region, which is not allowed. So we have to do the adaptation. Now, for DIBH, all of a sudden, we have coached the patient, it was perfectly okay. All of a sudden, one day, he forgot how to take the DIBH. And we are end up with, we cannot give the treatment. Like that, it's not about forgetting the treatment. From the outer external, as I told you, as a Arjuna, you have to rely on reflection. So, in few cases, there is a deformation of the internal organ. Like here you can see the liver has been deformed. So that has put up the dose and we are having an underdose over here. That cannot be delivered. So we have to adopt this patient. It's not, external is perfectly okay. Your target coverage you can see is perfectly okay, but your duodenum has come inside the high dose region. So you cannot deliver this dose. So you have to go for adaptation. So there are n number of difficulties while implementing this motion management. We ramp up our treatment like first breathing, free breathing we have implemented in 10th of August 2019, followed by 10th, this is in the 8th of October, followed by in 25th June 2021, we have implemented our first compression belt patient. So till date, we have treated more than 14 number of patients, out of which 56% of patients we have treated with free breathing, and 40% we have treated with breath hold, and fours are it's a compression belt. It's a very, very less because we have started yet. Out of that, the main the sites we have covered are lung, liver, pancreas, lymphoma, and esophagus. Esophagus, we have used only once breath hold. Otherwise, the maximum liver is the site where we use almost every patient with the DIBH technique. So, points to remember: perform basic measurement using a moving phantom to establish a threshold of motion amplitude where the interplay effect is small. So we have to have your measurement data to implement the motion management. Evaluate the tumor motion using a 4D-CT. Perform motion analysis to determine the motion mitigation if necessary or it is sufficient. Or if it is not sufficient, please go ahead with no treatment with proton therapy. Use dose distribution calculated, not only T0, T50 like the phase 0 or phase 50, you have to do it for all the phases also. As per planning, use rescanning, either it be a layer rescanning or volumetric rescanning to reduce the interplay effect. Use SFO plans with multiple fields, which is nothing but a replica of volumetric rescanning. Fractionated treatment delivery also provide effective rescanning. And use breath hold or compression belt or getting if needed with respect to the motion. Use 3D robust optimization to minimize the impact of organ motion. If it is available, you can go for 4D robust optimization also. And perform verifications, 4D-CT or DIBS CTs. As I told you, there are lots of problems in mitigating the motion. Evaluate the dose on verification CT for possible adaptation. Adapt the you have to adapt to your available tools for motion mitigation, because it is not like it comes with your machine. You have to have a third-party machine and you have to make them talk with each other. And always adhere to the limiting factors available with your system. And you should know what is the advantage with your system. So, before finishing, I want to just thank my team members. We are always backside me, but it cannot be done with the whole team of radiation therapists, 2 medical physicists, 2 radiation oncologists, and all should come in one shoe or in same attire, like we do in our festivals. Thank you.
Thank you, Dr. Patro. I think that was a good overview of motion mitigation. Though I don't see any questions in chat, if somebody wants to ask, I will allow, or yes, Dr. Kannan. Please go ahead.
Thank you, Dr. Karthikeshwar Rao. What is the dynamic 4-dimensional dose?
Sir, in proton therapy, we deliver the treatment with respect to spot by spot, to layer by layer, to cover the volume of the target. So there is a time lag between spot to spot. There is a time lag between layer to layer. So if you include that time with respect to your breathing and calculate the equivalent or dynamic, the dose, then it is called the 4D dynamics or dynamic 4-dimensional dose.
Thank you.
Okay. So it's great about the respiratory motion. What about the cardiac motion?
It's a very difficult task to actually visualize the cardiac motion. As we know, cardiac motion is very, very fast. So, yeah, the thing is, as I told you, the interplay effect depends on that motion rate. Our breathing motion rate is hardly 12 to 15, but cardiac motion rate is 72. So that 72 cardiac motion rate take care of the dose what you call dose blurring or what you can say. I just forgot that. Sorry, can you? Dose mitigation, actually, mitigating that motion.
Okay, so basically, what is the estimated dose with the movement? It goes to the cardiac structures there. So you have any range?
Estimated dose with respect to what? Means with respect to motion?
Cardiac motion.
As I told you, cardiac motion is almost 5-fold than your normal breathing motion. And I have mentioned that the moment you fractionate or the moment you increase the number of beams, that will take care of the motion effects. So cardiac motion will by itself take care of these effects.
Okay, that's a great one. So I think...
Can I have a question, sir?
Please go ahead.
Yeah, Karthik, a very good talk. I appreciate that, the way you put it and started. I just would like to understand, in your talk, you said that you are using that motion monitoring by SGRT.
Yeah.
If I understand correctly, you are using that, SGRT by Align RT, wherein probably you do not have the deformable image registration algorithm, which will be more impactful for, the cases like lung tumors.
Okay.
So do you think that, what is that, the limitations you feel, or it is not necessary that, the deformable is not mandatory to have it, but because the proton and photon, the motion is totally different. I just would like to understand from your experience.
It's not about proton or photon. As I told you, the SGRT system is not a, what you call, it's just a guiding system. It just shows you what is the motion parameters or what is the breathing pattern. It's not show you what is the deformation inside your body. It is shows the deformation outside your body. Okay, so this is a complementary to your CBCT. Always when you are using Align RT system, your base will be always CBCT. You have asked the patient to take a deep breath hold. You have taken a reference. On that reference, you have taken the CBCT. Okay, you match the CBCT and take that reference. Now this reference corresponds to the internal movement of this CBCT motion. Okay, so either it will be a deformable registration with respect to SGRT or a rigid registration that will not make that much of difference.
What kind of algorithm you have in CBCT to correct for deformations? Do you have that? What kind of algorithm in proton CBCT? Do you have that, deformation algorithm?
Algorithm wise, I am not sure, but yeah, Dr. Daya want to.
Can I come in? I think, of course, you did the deformable image registration is being used in another system, which is, we call it CRAT. And there has been a comparison between these particular systems and the SGRT, and that has been put up in one of the TG, which is going to come up. And this is the way how the two different systems works. And right now, I think so SGRT systems rely mostly on the selections of the ROI, whereas the other systems rely most onto the deformations of that particular structures. The questions arises whether you really need to do that or not. Okay, so these are different process for same solutions, and each one has got its advantages and disadvantages. And in this, I think we rely more on to our ROI selections, which we have validated extensively in our phantoms and as well as in patients. And if you see the upcoming task group report, I think the results are very, very similar. And of course, I think in none of the image registrations we use to guide the patient, then we don't use the deformation. Deformations comes only when we try to adapt the dose distributions. And I think, just to conclude, I'm not able to hold myself that I think, I'm not saying as a colleague, but I'm saying as a attendee of this particular conference, and this is the best motion management talk I have ever heard from any medical physicist.
Thank you.
Covering all the challenges what we face in the day-to-day practice. Thank you, Karthik. Thank you very much.
Thank you very much.
Thank you, Dayanand. There is one more question in the chat box, but I think Dr. Patro can take it and reply on the chat box. And I completely concur with Dayanand. That was a beautiful talk, right? A really beautiful talk. May I request now
Thank you,
the
everyone.
second speaker, or Dr. Kannan, you would like to go ahead with the second speaker? Or shall I? Okay. Pranshu, which I fondly call him, uh, is a dear colleague, and he is currently an associate professor at University of Maryland and alumnus of TMH. He is really a great guy, a great radiation oncologist with a clinical and research interest in thoracic. Probably I may have influenced him sometime, gynecological and hematological cancers. And believe me, he has played really few first ones in initiation of very advanced techniques in MRI, like MRI uh, backed up malignancies in, no. So basically he has worked in the cervical cancers with the MRI based brachytherapy. He has worked extensively for the cardiac ablation, radiation ablation, and other many hematolymphoid malignancies. And believe me, he's one of the great guys, great friend of APCC and TMC. So he's always reachable. Thank you, Pranshu, for coming up, right? And I know you'll do great. Good job. Go ahead, Pranshu.
Mohendra, Associate Professor of Radiation Oncology at the University of Maryland School of Medicine and affiliated with the Maryland Proton Treatment Center. Today, I'll be speaking on proton therapy for lung cancers, the journey so far and the road ahead. I don't have any financial disclosures relevant to the topic other than my employment. So looking at the topic overall, I decided to split this into clinical indications. I would not be covering aspects of such as motion management, robust optimization, and LAT planning, which is being covered by my physics colleagues. So we'll look at the journey where we are farthest ahead in the form of re-irradiation, area where we have made considerable strides, but the journey is still ongoing for locally advanced non-small cell lung cancer, an area where we are just getting started, where proton therapy can be combined with immunotherapy. We would look at some restricted use and service roads access, including port for surgically resected disease, small cell lung cancer, and stereotactic body proton therapy for early stage disease. We'll end with some special situations, including interstitial lung disease, lung transplant, poor PFT, and isolated mediastinal nodal recurrence. So re-irradiation or recurrent non-small cell lung cancer is a very important indication. Even in recent studies, the local regional recurrence rates have ranged from anywhere between 30 to 50%, and often causing significant morbidity and mortality risk. Re-irradiation is a feasible option, though it's limited by the risk of serious toxicity and hence often not used with systemic therapy considered as a preferred approach. There are unique dosimetric benefits of proton therapy, which may be relevant for re-irradiation, and results from early institutional and prospective collaborative groups using a mix of proton beam technologies have shown encouraging results. So let's take a look at this multi-institutional prospective study of re-irradiation with proton beam radiation therapy for local regionally recurrent non-small cell lung cancer, looking at 57 patients over a 5-year period with a re-irradiation dose to typically of a definitive range, and almost a year and a half of time interval between the radiation course, and encouraging PFS and overall survival was noted. However, in this initial prospective experience, the risk of grade 3 late toxicity and grade 5 toxicity was still prohibitive, recognizing that these are still early experiences with proton therapy in this setting. The Proton Collaborative Group at the University of Florida presented a prospective registry experience from multiple institutions looking at our experience with proton therapy, again in almost 80 patients with patients treated with definitive treatment intent and re-radiation delivered either with conventional hypofractionation or other similar fractionations, and a median time interval similar to the prior series, a median PFS and overall survival was noted of 10 to 15 months, encouraging for the patient population. In this more modern experience with a mix of pencil beam scanning and passive scatter techniques, the relative grade 3 and 5, rather the absolute grade 3 and 5 toxicity risks were much lower than the prior series. We at Maryland Proton Treatment Center have also been treating patients with proton beam therapy using pencil beam scanning or intensity modulated proton beam therapy technology. We presented our data at the multidisciplinary meeting in last year, again looking at about 62 patients all treated uniformly with IMPT with a mix of hyperfractionation, conventional fractionation, and some hypofractionation. The median time interval in our population was longer than the prior two series that we just reviewed, but the median re-radiation dose was in the same dose range, with the cumulative dose reaching almost 125 grade 10. In our experience, the median overall survival was noted to be about 22 months, and the median of freedom from local progression had not reached on Kaplan-Meier estimates. Looking at toxicity, acute grade 3 or more toxicity was seen in 12% patients, and late grade 3 or more toxicity was seen in 13% of patients. Again, overall encouraging outcomes in our typical clinic. We use proton therapy for scenarios like this, where, as you can see in this superior sulcus tumor, where on one side there is spinal cord, anteriorly there is esophagus and trachea, and laterally there is brachial plexus, and the target is sitting right in the middle. And we can see with using IMPT technology, we can very nicely carve the dose away from spinal cord, esophagus, and plexus while delivering therapeutic doses of radiation. So I would summarize that re-radiation with proton beam therapy is a feasible option with encouraging local control and survival seen in some recent series. There is still possible serious risk, especially from central structures, and careful planning is needed. When seeing patients in clinic, I typically tend to account for time from prior radiation and the volume of overlap to decide choice of fractionation and also use of concurrent regimens. Intensity modulated proton therapy may provide unique dosimetric benefits that are relevant for re-radiation more than passive scatter technique, and that would be the area where we need to look ahead. In addition, with increasing systemic therapy options, re-radiation will continue to remain an important tool, and we need to now demonstrate safety in combination with immunotherapy regimens. We definitely need larger mature data with IMPT and generate some more guidance with regards to OAR constraints when doing re-radiation. And then future hopefully will allow us to carefully select our patients using NGS and other such biomarkers. So I would say that re-radiation is a clear indication for using proton beam therapy. The caution continues to be warranted. Looking ahead, an area where there have been considerable advancements in the availability of data with use of proton therapy is locally advanced non-small cell lung cancer. As we know, the technology to treat lung cancer evolved from 3D CRT to IMRT VMAT and now to proton therapy. And when we moved from 3D to IMRT, there was improvement in outcomes noted, as is in this secondary analysis of the RTOG 0617 study. The IMRT group consisted of larger target volumes, more advanced nodal disease, yet it was able to demonstrate reduced cardiac and pulmonary doses, and this resulted in improvements in the rates of grade 3 or more pneumonitis, with IMRT being a significant factor on multivariate analysis predictive of a grade 3 or more pneumonitis. At the same time, data from studies like RTOG 0617 and other institutional experiences have also brought to light the importance of cardiac dose even in the setting of non-small cell lung cancer. And again, all dosimetry parameters to the heart having been linked with overall survival outcomes. So clearly, we still need to make improvements, and this is where there could be much added advantage of using proton beam therapy even beyond IMRT and VMAT. In this case example of one of my patients, as we can see on the left, with IMRT VMAT, excellent dose distribution can be achieved on the target volume, limiting dose even to the contralateral lung, but it still comes with this at the cost of spreading some radiation dose into the heart, coronaries, spinal cord, and of course other mediastinal structures. And with using proton technology, we have IMPT. We are able to more concisely and achieve conformal distribution around the target volume and be able to achieve really excellent sparing of cardiac substructures, esophagus, and spinal cord is very often not even a relevant OAR, which is very unique for non-small cell lung cancer. So looking at some experiences in this, I think MD Anderson initiated their prospective study, which was presented and published in 2017. And in this initial experience of 60 patients, mainly using passive scatter technology with a fair number of patients treated with chemoradiation, the median and 5-year overall survival and PFS were noted as below, very comparable to series available at that point. Grade 3 pneumonitis was also very encouraging in about 12% of patients, with the signal suggesting lower rates than IMRT based on historical data. They went ahead and conducted this Bayesian adaptive randomized trial of passive scattered proton therapy as compared to IMRT for locally advanced non-small cell lung cancer. This also included some patients with oligometastatic disease. And in this randomized trial, which by virtue of the Bayesian randomization, lined up going in favor of IMRT in terms of patient accrual. But again, patients were randomized if they met the DVH criteria for the treatment plan. The primary outcome was a consolidated endpoint of grade 3 or more radiation pneumonitis and local recurrence within 12 months. And contrary to expectation, there was no significant differences noted between passive scatter proton therapy and IMRT, and grade 3 pneumonitis rates were also not significant, but maybe numerically larger with passive scatter treatment. On further review, the passive scatter patients were seen to have larger treatment volumes. More patients received a full dose of 74 gray, with larger lung volumes receiving more than 20 gray. Also, something interesting that was noted in this series was a steep learning curve with use of proton therapy, and the outcomes for patients in the second half of the cohort was much better. And so, again, this has been an area where continued data has evolved in their follow-up series of IMPT versus passive scatter proton therapy, with about 86 patients getting passive scatter and a little above 50 patients getting IMPT. They did not see any significant differences in local control, local regional control, and distant control, with a trend to slightly improved overall survival with IMPT. This was very important data because there was concern that technologies like IMPT would be very significantly impacted by motion and the air tissue interface, and hence there was a fear that IMPT or proton therapy in general might be associated with higher rates of recurrences. As they looked at further at the adverse events, the grade 3 or more pulmonary toxicity and the cardiac toxicity was actually reduced with the use of IMPT as against passive scatter technique, again suggesting that with improved technology and better experience, the outcomes can be improved. In this multi-institutional prospective registry experience from from the PCG, with almost 200 patients, of which 1/5 of the patients received pencil beam scanning or IMPT treatments. Again, overall, very limited adverse events were noted, with less than 2% rates of grade 3 or higher esophagitis and pneumonitis, and excellent overall survival. But more interestingly, on multivariate analysis, use of pencil beam scanning was associated with reduced mortality, supporting the use of more advanced proton technologies. Mayo Clinic also published their experience comparing IMPT versus IMRT, and in this relatively small retrospective cohort analysis of definitive treated patients, chemoradiation patients, there was no clear difference in survival or outcomes or toxicity between the two groups, even though the IMPT patients tended to be older, more oxygen dependent, and also included some re-radiation patients in this data set. An NCDB analysis of proton versus photon therapy in non-small cell lung cancer, with about 350 proton patients being compared to a really large denominator of photon patients, but matched with propensity score analysis. A 5-year overall survival was noted to be better with proton therapy as shown with a really good separation of curves. Of course, with any NCDB analysis, there are certain variables and data that is not clearly available, and hence there's always some subjective, some potential for bias and skewed in the analysis that can be seen. So moving along, where can outcomes be improved with using advanced technology? And that's where hypofractionated proton therapy, even in the setting of locoregionally advanced non-small cell lung cancer, becomes an option. In this phase 1 study of University of Florida and Proton Collaborative Group, patients were accrued and escalated with dose per fraction escalation from 2.5 gray all the way to 4 gray, keeping the total dose at 60 gray. The study closed early due to poor accrual from competing trials and other insurance-related risk factors. And overall, 2 serious adverse events were noted at level 3, which were felt to be related to from chemotherapy. Again, this data set was in the pre-durvalumab era. A follow-up of phase 2 portion of the study was published recently that we participated in. And again, in this chemoradiation treated patients prior to the durvalumab era, treated with a broad range of 2.5 to 4 grade fractions. No significant grade 3 or more esophagitis was noted. Grade 3 or more pulmonary events were noted in about 15% patients. And 1 and 3 year overall survival was very encouraging for this patient population. WashU recently presented their phase 1 study of accelerated hypofractionated proton therapy and chemotherapy. Unlike the PCG and University of Florida study, this cohort included total dose escalation, keeping the dose per fraction constant at 3.5 gray. And with a median follow-up of 20 months, no DLTs were seen in the assessment window, though a cumulative 2-year grade 3 or higher AE risk was about 21%. Again, like the prior experience, the 2-year local control and overall survival was excellent even in this series, which is pre-immunotherapy. Another approach for biological dose escalation is using simultaneous integrated boost. And so in this initial experience from MD Anderson, comparing SIB with IMRT versus SIB with IMPT, and then escalating dose levels while keeping the target or PTV dose constant at 1630 fractions. Overall, DLTs were seen as shown, 11% at first dose level and 33% at the second dose level. The highest SIB level was reached at 78 gray with IMPT, as against 72 gray with IMRT. So what do we see in non-small cell lung cancer locoregionally advanced with use of proton therapy? And early evidence failed to show any significant benefit over IMRT, but it was realized that there is a learning curve with the proton beam technology, and the use of passive scattering technique is possibly a limiting factor. Modern data is showing some exciting outcomes with IMPT, demonstrating reduced cardiopulmonary events. The mature data is needed, and of course we are awaiting completion and results from the NRGR-TOG 1308 study that's randomizing proton therapy with IMRT VMAT. There is evolving data on hyperfractionated and SIB proton techniques combined with chemotherapy, and of course future studies would also explore incorporation of immunotherapy. I think I would summarize this data saying, picture abhi baki hai mere dost. For the non-Indian audience, this is a Bollywood movie reference suggesting storyline is still evolving, and we'll need to wait and see how this data ultimately evolves. At our center, we tend to use IMPT for patients that have very heavy disease burden, like this case example with really large right upper lobe tumor, and including heavy mediastinal and contralateral nodal burden. And even in this setting, IMPT allows very limited dose to the contralateral lung and even mediastinal structures, including heart and esophagus, which is really impressive with the use of IMPT. We've also invested a lot of effort in using gated voluntary breath hold IMPT for thoracic malignancies, and publications are currently under review on this topic. So where are we in the early stages? And that's with combination of proton therapy and immunotherapy, and where I would provide an initial kind of a glimpse of why this could be beneficial is this series that compared proton beam therapy versus IMRT, and which demonstrated that the reduced irradiated lung volumes of proton therapy were associated with lower risk of severe radiation-induced lymphopenia, and whether that can translate into better response rates to subsequent immunotherapy, of course, remains to be seen, but this is really exciting to see some differences. We looked at our own database at University of Maryland, and in our smaller cohort, we did not see any statistically significant decrease, even though numerically there was a difference noted in the lymphopenia rates between proton therapy and photon IMRT-VMAT therapy. So trying to wrap up the rest of the presentation, we look at some areas where I would call there's restricted use or service road approach. And the biggest component of this is post-operative radiotherapy for patients with N2 non-small cell lung cancer. This is an area where the proton world was very excited about with really clear benefits anticipated with use of proton beam therapy. But as that journey was just getting ready, data from studies like the PORT-C study from China and the LungArt study demonstrated that while there may be a hint of DFS benefit, there is no overall survival benefit demonstrated with routine use of PORT in N2 patients. There may be benefit in reducing grade 3 or 4 cardiopulmonary toxicity, but even that difference may not be uniform in different series. Nevertheless, there has been some data that has looked at use of proton port for surgically resected non-small cell lung cancer in this initial single institution series from MD Anderson, a retrospective review comparing proton beam therapy with IMRT. Majority of the patients were still passive scatter, did not demonstrate any improvements in survival, PFS, or local control, but they did see reduced cardiopulmonary toxicity even with older proton technique, with cardiac toxicity reduced from 14 to 5%, p-value 0.09, and grade 2 or more pneumonitis reduced from 17 to 5%, not statistically significant though. In our own experience, we've used PORT predominantly for positive margins for non-small cell lung cancer, thymic malignancies, and occasional small cell lung cancer. And in this experience overall, as you see with the table on the right, the risk of grade 2 or higher toxicities were very limited, and grade 3 or more toxicities also were less than 5%. Again, we really felt that this is a really important indication for use of proton therapy. But with the data, I guess we can see as an example like this, in this patient with post-left upper lobectomy, where essentially patients relying on the right lung and very low volume of residual left lower lobe remaining. The proton therapy significantly limits the dose to the target area, and the contralateral lung essentially gets no radiation dose. And so proton therapy has demonstrated signal of effect of reduced cardiopulmonary toxicity, though long-term data will be needed from prospective cohorts. While PORT should not be standardly offered to all N2 patients, there is possible indication in patients who cannot receive planned systemic therapy or patients with positive margin, and these are the patients that we typically treat using intensity modulated proton therapy at our center. There's also a possible role for salvage of isolated nodal recurrences that will happen when PORT is avoided or skipped, and that could be another area where proton therapy could have a role. So again, restricted use or a service road is how I would put proton PORT. Limited stage small cell lung cancer, not a lot of data. This prospective study from University of Pennsylvania with 30 patients treated with BID or once daily treatments showed overall excellent outcomes for this patient population. I think the biggest concern with small cell lung cancer is the rapidity of tumor response requires a significant adaptive replanning. And in this cohort, about 10% of patients needed a replan. And the grade 3 pneumonitis rates were really low, 3%. So very early data shows feasibility for using proton therapy in small cell lung cancer. These are sicker patients, there's urgency to start treatment, disease response can be very rapid, and these are the challenges that we have to account for when using proton therapy. There's likely going to be benefit in patients with heavy mediastinal burden by reducing cardiopulmonary dose and lymphopenia, which has implications for immunotherapy. So restricted use data is evolving. For stereotactic treatment for early stage lung cancer, SBRT is now the standard of care for medically inoperable disease. The outcomes are almost competing with surgery for operable disease with very low toxicity profile, especially in centrally located and larger tumors. And dosimetric studies between SBRT and using protons have shown overall comparable outcomes with minor differences here and there, except for this population of centrally located or larger tumors. This is where SBRT can be limiting, and a variety of fractionation regimens with photons have been used, ranging from 5 to 15, depending on the degree of target volume. And the proposition is that maybe proton therapy could help be more useful in this patient populations. In this phase 2 study, looking at SBRT with proton therapy for high-risk medically inoperable patients, which were centrally located or with mediastinal or pericardial involvement. The study did not complete accrual, but overall, local control between photons and SBRT and proton SBPT was comparable. An area that I would like to highlight from this figure is the dose differences. The central hotspot does tend to be much lower with proton treatment, something that can be optimized with using IMPT, but there is still uncertainties related to the large tumor to air ratio for these smaller tumors. And of course, the distal RBE uncertainties from high dose fractions. So in our center, our approach still is using caution when using proton SBPT, and we only reserve it for patients that are really large tumors or very central tumors that are not amenable to photon SBRT. I would say that there's no clear benefits over SBRT. It lacks the central dose distribution of SBRT with uncertainties of dose delivery and RBE differences. And so the journey with proton SBRT is unlikely to go too far outside of those select scenarios. Very quickly ending with some special situations. In interstitial lung disease or idiopathic pulmonary fibrosis, these are the patients with very poor pulmonary function and are at very high risk of cardiopulmonary toxicity with standard chemoradiation. And in this Japanese initial experience of idiopathic or interstitial pneumonia patients with a median follow-up of almost 2 years and excellent local control and overall survival to definite treatment, the grade 3 or more pneumonitis risk in this very high-risk population was really only about 10%, which is impressive. This is a case example of that I have treated, as you can see in the picture on the left, significant interstitial lung disease. A patient was already on oxygen and really large volume disease. We were able to treat with definitive doses, and you can see impressively low dose to the heart, the contralateral lung essentially getting no dose, and even the esophagus getting very low doses. Another patient who had a single lung transplant on the right side with just barely any functioning lung on the left side with heavy volume, limited stage small cell lung cancer. We treated this patient with BID, again dosimetrically superior heart, lung, and esophageal doses. This patient was able to complete treatment without any challenges. One final unique indication would be patients that have received prior SBRT and now have mediastinal nodal recurrence. Like in this case example, patient had bilateral left and right SBRT and now had isolated mediastinal nodal recurrence. And again, we were able to treat this. Sorry, this is a typo with 66 grain 33 fractions and very impressive dosimetry to the mediastinal structures to be able to use proton therapy. So overall, I'm a minute over, but I think we've reviewed overall the journey with proton therapy for lung cancer and where we have made significant progress, and it's a clear indication, which is re-radiation. Data is still evolving in locally advanced non-small cell lung cancer. The promise is seen, especially when we start combining it with immunotherapy. There are some restricted uses for port in positive margins or those who cannot get chemotherapy. Some small cell lung cancer patients that have really heavy disease burden, and very limited stereotactic body proton therapy for patients that have centrally located a large volume disease. And then the special situations of interstitial lung disease, lung transplant, and isolated mediastinal nodal recurrence is area where proton therapy has demonstrated use, and we would continue to evolve data as we move forward. Again, I would like to thank the chairpersons and the organizing committee for this opportunity, and I would be happy to take any questions. Thank you.
Thanks, Pranshu. I think that was quite panoramic view, you know. I really got emotional also when I was introducing you. one thing, that was a bold treatment. I would not have dared to treat those so-called special cases, you know. I'm really, really, and congratulations on treating those bold ones, special cases, you know. Its questions are open for the floor to.
Yes, Dr. Agarwal. Dr. Pranshu, it is nice to hear the journey so far of the protons and the road ahead. Wonderful to hear. Excellent sum up, including a personal experience. I, as a doctor in Mumbai, we have a center in Chennai. Okay, I did refer a case of a proton therapy because after chemotherapy, locally advanced lung cancer, he did have a large, high amount of dose to the heart, not acceptable. Went to Chennai, had an excellent response 2 years down the line, doing extremely well, very good about it. Still, the data you have shown are not still impressive enough for me to send, for me to talk, yes, you do go for the proton therapy. Your reaction to this?
Yeah, thank you, Dr. Kannan. I think before I start, I do want to say again, it's always a pleasure and an honor to present with all of you all. And of course, I've trained under Dr. Agarwal. And yes, Dr. Agarwal, sir, you were the reason that thoracic radiation oncology is so important to me. On the same line, Dr. Kannan, 18 years ago, you were the reason I got into radiation oncology as I was exploring radiation oncology as a field. And so thank you for getting me here now 18 years later. Coming to your question, I think the indications are very varied. Now here for us at Maryland, we have access to proton and photon technologies essentially across the street. And so for me as an individual physician, I'm able to choose which one is more appropriate for a given patient scenario and then decide whether one technology supersedes the other in terms of anticipated outcomes. In a setting like where you are, whether the decision to have a patient travel all the way from Mumbai to Chennai will truly depend upon the dosimetric differences that you are anticipating or you're observing with the treatment plan. I think a very good first step is to really do a nice VMAT plan to see what dosimetry are you able to achieve. If as a provider you are wanting to reduce the dose to the target volume or you're uncomfortable delivering meaningful radiation doses, then I think that will become a good subjective decision to say, okay, for this patient, if they have the means to travel, then a trip to Chennai might be worthwhile. Examples being those special cases like Dr. Agarwal pointed out and many other scenarios. I think, again, having seen a lot of comparison plans between IMPT and IMRT, there are really clear benefits of using proton therapy for left-sided tumors, significant cardiac overlap, large burden mediastinal nodal disease, or contralateral nodal disease. These are the patients where we have stopped doing comparison plans because the dosimetry is so superior with IMPT that any comparison is not worthwhile. But at the same time, VMAT is a really good treatment technology and some amazing treatment plans can be generated with careful planning to reduce dose to the heart and contralateral lung, even with VMAT techniques. And so I think in many of those patients, standard photon treatment is definitely acceptable.
With the permission of chairpersons, I also would like to make a comment to Dr. Kannan's question. Although I was about to ask a question to Pranshu, but sir, I mean, of course, that patient is still doing well. We are very happy about it. But you asked a very apt question. And based on our experience so far in the last 3.5 years, I agree with Pranshu that bulky tumors, left-sided tumors, lower lobe tumors, N2 disease, or N3 disease, the contralateral hilar nodes, those are the patients who would clearly benefit. And as Pranshu rightly said, probably there is not even a need to do a comparison plan and see how much proton is beneficial. It's not whether proton is beneficial or not, it's by how much. So I think if at all you see a patient who has a bulky lower lobe primaries with bulky mediastinal nodes as well as contralateral mediastinal nodes, contralateral hilar nodes, probably those are the direct indications where you could consider them for proton therapy. Coming back to Pranshu, really thankful, really proud the fact today that you did a full justice to the title of the talk. and you took it really seriously. I mean, you went up to the service lane as well. Thank you for that, and especially I'm very thankful to you for going that extra mile. I mean, staying awake at 2:30 in the night. I know these are busy days for you with your baby, but really thankful for joining us today. But I have two questions for you. One is, what do you envisage the advancements in proton therapy, especially in the context of newer proton planning, like LET optimization, RB, variable RB modeling, and do you think the proton field is going to move in a better direction with all these newer proton therapy advances? And number two is in patients who go for re-radiation, which you mentioned probably the most robust evidence for easy indication for proton therapy. How do you manage doses to the proximal bronchial trees and the pulmonary vasculature? I mean, are there any tricks and tips which you could give us based on the publications you have mentioned? Thank you.
Yeah, thank you, Srinivas. So I think it's always going to be a bit of a comparison plan and trying to expand your experience. I know, as I have gone through personally my own journey in getting more and more comfortable using proton therapy, our aggressiveness with treating and our ability to treat doses to the much higher dose structures keeps getting better over time. So I think I'll answer your second question first in terms of proximal bronchial tree or re-radiation in those scenarios. We often try to make sure that luminal structures, the contralateral wall of the luminal structure does not get the definitive treatment dose. And especially with IMPT, we are able to try and limit dose only to the adjacent adjacent luminal wall to the treatment area. This requires working with our physics and dosimetry colleagues. Oftentimes we will accept compromise to robust optimization, and instead of aiming for a 95-95 or a 5% uncertainty, we would typically accept a little bit higher uncertainty as well, recognizing that there's a balance that we need to do between tumor control and toxicity. So I think that's how we would approach it. In general, fractionation plays a key role into that. In one of the chat boxes, this question Dr. Mumudi had asked, if a patient has had a really long time interval from prior radiation, then I'm comfortable doing 1.8 gray fractions or once daily fractionations. But if the treatment time is short between the radiation courses, or if their treatment volume is large, then I would sometimes consider BID fractionation. But this is an area where personally, I have stayed away from doing hypofractionation-based re-radiations just because of the uncertainties and because our treatment planning, and this leads me to your first question, our treatment planning has still not incorporated LET-based planning. I know one of the talks later today will go into this a little bit more, and I would see that the biggest benefit of LET-based planning will be for re-radiation, especially because patients get treated with a variety of fractionation, and just doing EQ-D2 calculations is probably not justice to those assessments. So I think LET-based planning will impact re-radiation. It probably will not have too significant bearing for our standard run-of-the-mill first-time treatment patients. That's how I would say. In terms of advancements further, motion management and the work that our enviable colleagues, Dr. Dayanand Sharma, again, I trained under you, I see you standing there. I think the smart people like you and Dr. Pathro, who presented an amazing talk, these are the reasons why our outcomes will improve with proton treatment as we do better motion management, better robust optimization, and account for different cardiorespiratory motion changes.
I want to thank Pranshu. I think we are overshooting the time. Dayanand, I will give you a very short one. Make it quick.
We can go ahead. No, I think we can go ahead to the next session, no issue, because time is so short.
No, I know, and I think you can.
But
ask
I just want to put.
box,
I just want to put
Pranshu
Dr. I just want to put a comment to Dr. Kannan. Or I think nice to see you, Pranshu. I think after a long time, only the difference is a little bit of gray here and your accent. And of course, I think I love your smile when you say picture Vivaki dose. Right. Okay. I think I wanted to discuss a lot, but I think because of the time, I just wanted to put a small comment on Dr. Pranshu as well as Dr. Kannan. that I think distance cannot be a factor, I think, to deliver the best to the patients. And we are always ready to provide you a comparative plan for proton and a photon in order to enable you to take a better decisions for any of your clinical indications. Thank you.
I really appreciate Dayanand. I think you'll get more offers from Mumbai. Having said that, I think it was a very nice session. I really enjoyed it. And especially on a re-radiation note, we need, when we're thinking of a LET based, we need to think a systemic treatment which is also going on. So that is really a gray area at this point of time. And I will hand over to Dr. Kannan for the next proceedings.
What is your time, Dr. Pranshu, now?
3.
Oh, 3 o'clock in the morning.
Very nice of you. Thank you. We'll move over to the next interesting topic, going to be on the hepatopancreaticobiliary tumors, proton therapy. And we have an expert, Dr. Christopher, who is going to be with us now. Dr. Christopher.
Conflicts of interest to disclose. I'll review the role of proton therapy for liver tumors, which includes hepatocellular carcinoma and intrahepatic cholangiocarcinoma. We'll review some of the clinical data supporting the role of protons. We'll discuss some practical tips, and then we'll discuss considerations for using protons compared to photons. And then finally, we'll briefly touch on the role of protons for pancreas cancer. So the rationale for the use of protons for liver cancer is the physical dose distribution benefit of proton beam compared to a photon beam. Specifically, there's less entrance dose and no exit. And with using multiple proton beams, we can concentrate the highest dose on the tumor with relative sparing of surrounding liver, which we can do to some degree with photon-based techniques, but really you get substantially less low and medium dose with the use of protons compared to photons. Some of the initial data looking at proton radiotherapy for HCC comes from Japan, which dates back to the 1990s. They had realized the potential of protons to deliver high-dose radiotherapy to liver tumors while minimizing uninvolved portions of the liver. They used hypofractionated regimens delivering a 2 gray equivalent dose of 80 gray or higher. This is one of their publications, including over 300 patients. These are patients that were not eligible for surgical treatments, and many had had prior embolization or ablation treatments. These patients had well-preserved liver function, and notably there were no size or location limitations. They largely used a moderately hypofractionated treatment regimen of 10 to 22 fractions over 2 to 4 weeks. They showed that they could achieve a 5-year survival of 45%, and specifically in patients with well-preserved liver function, the 5-year survival was 56%, so on par with other curative intent local therapies. They were able to achieve these outcomes with fairly low risk of severe toxicity, and the local control rate was 87%, with most of the recurrences happening elsewhere in the liver or at extrahepatic sites. There have now been several single-arm prospective studies done in Asia and in the United States that have demonstrated the safety and efficacy of moderately hypofractionated high-dose proton treatments with local control rates consistently reported in the range of 80 to 90%. We recently published our initial experience using IMPT for hepatocellular carcinoma. We had treated 37 patients. These were mostly large tumors and patients that had failed other local treatments. We had a relatively short follow-up of 21 months, but we did not observe any severe toxicities, and 16% of patients had worsening of liver function. With limited follow-up, our local control was quite good, and overall results were consistent with other published trials, which were predominantly in the using passive scatter techniques. Switching gears to intrahepatic cholangiocarcinoma, this is a less common tumor, so there's less data, but the key study to be aware of is a prospective single-arm phase 2 study that was run by Mass General, MD Anderson, and Penn. They treated patients with a moderate hypofractionated regimen, and they observed a promising median survival of about 23 months with distant recurrence being the more common mode of failure than local recurrence. In fact, local control was quite good, and as mentioned, overall survival looked promising. So how do we choose patients for proton therapy? Well, good patients would include those with well-preserved liver function, liver-confined disease, and either unifocal or limited multifocal disease. Contraindications are poor performance status or limited life expectancy, patients that have uncontrolled or extensive extrahepatic disease, patients that have more than 3 discrete intrahepatic lesions, those with decompensated liver disease, or those that have received prior radioembolization to large portions of the liver. Before we treat a patient, we would typically place fiducial markers to facilitate IGRT. We have our radiology colleagues place 3 to 4 carbon fiducial markers. We choose these over gold because they have less scatter artifact and less perturbation of the proton beam. For select patients, we've also had our surgical colleagues place a mesh spacer that creates space in between the liver and the stomach. We, again, use this selectively for patients in which there's a long stretch of tumor directly abutting a GI luminal structure. We simulate patients supine on a green foam pad with their arms up. We do a 4D CT scan and assess motion. If the fiducial motion is less than 1 centimeter and there's no overlap with a critical organ at risk, then we use the full average with the isolayer repainting technique. If there's 1 centimeter or more of GTV motion, or there's overlap with an OAR, then we typically would use a phase-based gating technique. We do a SIM with IV contrast using a biphasic liver protocol, and we do an MRI in treatment position. For treatment planning, we typically will use 2 to 3 beams, and we'll select beams that we feel are most robust. Specifically, we avoid beams that pass through air or ascites. We start with an SFO technique, and if we're not able to achieve OAR constraints, then we'll switch to MFO. We use Eclipse robust optimization with 5 millimeter and 5% uncertainty, and then once we have a plan that we like, we'll cast that on the respiratory extremes and also a scan in which the air is overridden. For IGRT, we start with orthogonal x-rays and use a 6-DOF couch, first aligning to spine to get the patient in the general position, and then shift to fiducials with a 5 millimeter tolerance. We also have an in-house software for doing fluoroscopic verification of fiducial motion on the respiratory cycles. We also have in-room 4D CT on rails for localization and for verification scans, and then we also will snap an X-ray in between fields to verify that the fiducials are still within the expected location. This is an example of an in-room 4D CT scan that we use for localization. We do weekly verification scans, with the first one being done typically on the first or second day. If we have concern about the robustness, we'll do the scan the day before. We found that about 20 to 25% of patients require adaptive replanning for most commonly changes in the anatomy, either changes in respiratory motion, development, or resolution of ascites or pleural effusion, like in this case shown below, or changes in dose to bowel based on bowel position. So a couple examples of patients treated. This is a patient with a large right lobe HCC treated with 5805 and 15 fractions. This is 2 years later, showing nice response of the tumor. This is a central lesion, again treated with the 15 fraction, moderately hypofractionated technique, and we see nice regression of the tumor over the subsequent 2 years. This is a patient with central intrahepatic cholangiocarcinoma treated with, again, a 15 fraction, moderately hypofractionated regimen. And we see nice regression of the tumor over the subsequent 2.5 years with normal liver function. So both photons and protons are very useful in the treatment of liver tumors. So which technique is better? As we previously mentioned, protons have the advantage of less low to medium dose to the uninvolved liver. Here's another case where you see a nice sparing of the posterior aspect of the liver, which with photons gets bathed in 20 to 30 gray. And this is a scan 6 weeks after treatment. You see nice demarcation of where the proton field was at, and there's hypointensity in the treated tumor, and there's nice hypertrophy of the part of the liver that was completely spared. There's a nice planning study that looked at varying tumor sizes between 3 and 16 centimeters that were planned with 60 and 15, either IMRT or proton beam therapy. It's an example of a 5 centimeter tumor treated with protons or IMRT and a 10 centimeter tumor. So you can see for a 5 centimeter tumor, the difference in the volume of liver getting 30 gray or a hepatic toxic dose is relatively modest. But when you increase the tumor size to 10 centimeters, it's a fairly substantial difference. And they plotted nominal GTV size versus risk of radiation-induced liver disease that would be predicted based on the liver dose, and you see a very sharp inflection point at about 5 to 6 centimeters where the risk of radiation-induced liver disease goes up fairly markedly with IMRT, whereas it stays about the same with protons. More recently, there's clinical data from Massachusetts General Hospital where they looked at their patients treated with HCC with either protons or photons, and they saw that local tumor control was similar between the two modalities. However, the risk of radiation-induced liver disease was substantially reduced with protons, and this translated into an apparent improvement in overall survival. This lays a groundwork for a phase 3 randomized trial that's being run by MGH, but through the NRG Oncology Cooperative Group, in which patients are randomized to either protons or photons with the radiation dose dependent on liver dose. The hypothesis is that the superior liver sparing and reduction in toxicity associated with this would translate into a survival advantage for protons. How do I approach these patients? Well, for a small tumor, solitary lesion, and preserved liver function, I favor photon SBRT technique due to the robustness, quickness, and simplicity of this treatment, the excellent IGRT. For larger tumors, bigger than 5 centimeters, multifocal, portal vein thrombus, or more significantly impaired underlying liver function, I prefer a moderately hypofractionated proton technique to maximally spare liver. So to summarize, we have clinical data supporting the safety and efficacy of high-dose proton radiotherapy for HCC and intrahepatic cholangiocarcinoma. We can achieve good tumor control with low risk of toxicity. Pencil beam scanning or IMPT techniques are feasible with careful planning and delivery techniques. Proton radiotherapy produces more favorable dose distributions and superior normal tissue sparing, especially for larger tumors, which would predict for a lower risk of severe adverse effects. And there's a randomized trial ongoing that's comparing the modalities head to head. Shifting gears to pancreas cancer, less data published on the use of protons for pancreas cancer. The rationale is a reduction in dose to organs at risk with proton therapy. We published our initial experience, the first 13 patients that we had treated using IMPT. These patients were treated with a similar technique as for the liver patients in terms of motion management and robust optimization. We generally use 2 posterior fields with an MFO approach. The posterior fields maximally spare the anterior bowel structures. Notably, many of the patients that we initially treated had biliary stents, and so we had overridden the HU for the stents in the planning process. As part of the study, we did a dosimetric comparison and showed that the dose to GI structures was reduced, especially in the V30 and V15 range. All 13 patients completed planned chemoradiotherapy. 4 out of the 13 had anatomic changes prompting replanning, and generally this was very well tolerated with minimal severe toxicity, no weight loss, and preservation in quality of life at the end of treatment compared to baseline. So to summarize the pancreas experience, relatively limited data supporting safety and efficacy, but the hypothesis is that the reduced OAR dose may improve the therapeutic ratio through reduced toxicity or the opportunity for treatment intensification. The use of protons for pancreas cancer is appropriate in select scenarios, and these are the contexts in which we use it in clinical practice. So specifically patients that have had prior abdominal RT or have unique anatomy. but certainly further prospective study is warranted.
Dr. Kamlan, we can move to the next speaker because Dr. Christopher was on online video presentation only. So I think there will be no questions to that session. If still there are any questions, we can ask Ashwati to answer on that behalf. Okay? Is it okay? So, will you call Dr. Ashwati or shall I? Shall I call Ashwati? Suravani, will you
Yes,
like
sir,
to
yes, sir.
call her?
No, sir. Please go ahead. Go ahead, sir, please. No issues.
Oh, Ashwati, there are so many of us to give the introduction for you. And the smile is beautiful, you know, before the lunch.
Thank you, sir. Thank you.
Again, Ashwati has been very close to us and really proud of Ashwati. She has accomplished so many things in a very short span of time on all fronts. Let me say that. She's a multitasker, I know that. And it is great to know Ashwati. She has, for others who don't know Ashwati, she has, after being an alumnus from TMC, she went for her further studies abroad at TMH, Maryland, Penn, and she has really done well on the thoracic as well as abdominal tumors. I really wish Ashwati the very best. Please go ahead with your nice talk.
Thank you, sir. Thank you for that glowing introduction. Thank you. I will try to live up to it, sir. So, just as an introduction, I'm Ashwati Matthew. I'm the consultant radiation oncologist in the gastrointestinal cancer management team here at the Apollo Proton Cancer Center. And in the next 20 minutes or so, I would like to present the current status of evidence for the use of proton beam therapy in the treatment of esophageal cancer. We know that esophageal cancer is one of the seventh most common cancer in the world, and in India that translates to around 50,000 new cases a year. India, unlike the West, has a higher proportion of squamous cell cancers, and especially patients from the Northeast region are have a very high incidence because they belong to this cancer belt with more than 100 cases per 100,000 annually. The role of radiation in esophageal cancers has evolved over the last 25 years or so, and currently it holds its own in the treatment of both resectable as well as unresectable cancers, that is both in the preoperative setting as well as in the definitive setting. In the preoperative setting, we have the results of the CROSS trial to guide us that the addition of radiation definitely improves the overall survival of these patients who undergo surgery thereafter. With this background, let's look at what is the rationale for using proton therapy in esophagus. As many of the previous speakers have alluded to, the primary rationale continues to be the physical benefits or the physical properties of the proton beam. The location of the esophagus in the middle of the thorax with both the lungs and the heart anteriorly and laterally results in a reduction in the intermediate and low dose isodoses. And this reduction turns into a clinically significant dosimetric difference between proton and photon treatments. So, because the intermediate doses are reduced, we can spare lungs and the heart from clinically significant doses. And this is expected to reduce the normal tissue complications, and it may even open a window for safe dose escalation of radiation dose to the tumor. There are also several biological mechanisms which have been proposed to further explain or as hypothesis to support the use of proton therapy in esophageal cancers, including the impact of decreased lymphopenia, in which I will describe in a little detail further. So there are several dosimetric studies, this is just one of many, which have clearly demonstrated that there seems to be a reduction in the doses or radiation doses delivered to the heart, both in terms of the mean heart dose as well as the doses received by the cardiac substructures, as well as the different dosimetric parameters that we evaluate for the lung. Now, among the technique, when you compare proton beam therapy with even techniques like IMRT, among the techniques of proton therapy also, the passively, compared to the older techniques of passively scattered proton therapy, IMPT seems to further increase the advantage that we have with proton therapy. Why is this important? Because although cancer deaths do form the majority of morbidity and mortality experienced by esophageal cancer patients, cardiac deaths are not to be discounted completely, as we see from this large retrospective comparison of 3D CRT and IMRT, where they have consistently shown that the use of IMRT reduces the cardiac deaths in these patients. So this begs the question, will the use of a more conformal technique like proton therapy further increase the benefit with respect to cardiac deaths by reducing the doses to the heart? The other aspect that I touched upon earlier was the impact of lymphopenia. So we know that lymphopenia, grade 4 lymphopenia does occur during radiation, especially during concurrent chemoradiation, which is the radical treatment for esophageal cancer. And this has also been shown by the study by Davuluri et al. To significantly impact the overall survival as well as locoregional and distant metastasis-free survival in patients with esophageal cancer undergoing chemoradiation with photon techniques. Further, they have demonstrated that proton beam therapy, when compared to photon-based radiation, reduces the incidence of lymphopenia. It also reduces the severity of lymphopenia, as demonstrated by the panel on the right, where you can see that the nadir level of lymphocytes, the number of patients with a lower nadir is also less with proton, as well as the nadir level itself is higher with protons. This has been seen, at least in retrospective studies, to be an indicator of a better pathological complete response rates. Pathological complete response rates in esophageal cancer have been associated with better survival outcomes as well. And so proton beam therapy seems to be a better predictor for a higher pathological complete response just by virtue of its association with the lymphopenia. On this background of the rationale, let us look at the clinical studies that are currently available, beginning with a small retrospective institutional series. This is one from MD Anderson. With their initial experience of around 60 patients, and basically demonstrating that proton beam therapy can be safely used with concurrent chemotherapy and with acceptable toxicity, and as expected, lesser locoregional recurrences in the group which underwent surgery after chemoradiation with photon. They also demonstrated that the dosimetric benefits that were seen in planning studies were effectively clinically demonstrated in this cohort of patients, with lower lung doses and lower heart doses in this entire cohort. This then led to a larger series reported in 2017 with almost 300 patients, and this they chose to focus on the patients who were treated with definitive chemoradiation. Comparing over a period of 2007, almost 7 years, the cohort of patients who were treated with proton beam therapy and IMRT. And in this analysis, they reported significantly better overall survival, progression-free survival, and distant metastasis and marginally better locoregional failure-free survival in the cohort which received proton beam therapy. The multivariate analysis again confirmed this, and so they proposed that esophageal cancer patients with locally advanced disease, proton beam therapy may lead to a better outcome, clinical outcome. This brings us to the currently the highest level of evidence available for esophageal cancer, and this is a randomized phase 2b trial again carried out by the MD Anderson group. comparing proton beam therapy versus intensity modulated radiation therapy. This started in 2012, was closed in 2019 after two-third accrual because certain early signals were seen in the interim analysis. And this recruited a cohort of newly diagnosed squamous or adenocarcinoma patients who received chemoradiation to a dose of 50.4 gray. They were randomized 1:1 to either IMRT or proton beam therapy and were stratified for the use of induction chemotherapy, potential resectability, stage, and histology, as in squamous versus adeno. So both unresectable and potentially resectable cases were included, and stages 1 to 3 were included. The pre-specified primary endpoints is something that we should discuss in a little detail. This included both progression-free survival as well as total toxicity burden. This was a unique endpoint which enabled the composite representation of the entire toxicity that an esophageal cancer patient experiences as he goes through chemoradiation and subsequent surgery and for the 12 months after. So you can see by the chart on the left, all these this tumor toxicity burden was a single numerical representation of the frequency as well as the severity of all these toxicities which are enumerated on the left. Now these toxicities include both lung as well as heart toxicities, both in the immediate postoperative time, such as anastomotic leak, ARDS, acute pulmonary embolism, strokes and reintubations while the patient is recovering postoperatively, as well as other toxicities which we see in the subsequent 12 months, like pericardial effusion, pleural effusion, radiation pneumonitis, and cardiac arrhythmias and myocardial infarctions. So the severity of each of these toxicities was graded. A numerical weight was assigned to these, and this was then numerically combined to form a single entity which is known as the total toxicity burden. This was a unique feature of this trial, and what they demonstrated in the 145 patients who were randomly assigned in this trial was that at the time of the analysis at the two-third accrual, the total toxicity burden was lower for proton beam therapy patients as compared to the IMRT patients. Because of which the trial was stopped, and this led to the subsequent initiation of the randomized phase 3 trial, which is currently ongoing. So this is a pictorial representation of this, which basically shows that the total toxicity burden was 2.3 times higher for IMRT as compared to proton beam therapy, and the postoperative complication score was 7.6 times higher for IMRT as compared to proton beam therapy. And the figure on the left also shows you pictorially that when you compare the IMRT arm and the proton arm, both the frequency of the complications as well as their severity were more in the IMRT arm as compared to the proton beam therapy arm. So this provides us with some definite evidence that proton beam therapy reduces toxicity in esophageal cancer patients who are undergoing concurrent chemoradiation, both in the preoperative setting as well as in the definitive setting. This is again supported by other papers which have come up in the last 4 or 5 years. For example, this comparative study from the University of Pennsylvania showed that the proton chemo patients, although this was an all-basket trial, for esophageal cancer patients formed almost 14% of these patients, and they demonstrated that proton chemoradiation was associated with less toxicity, acute toxicity as compared to the photon chemoradiation cohort. The Mayo Clinic has also reported their now, with respect to the randomized phase 2b trial, which I just described, the majority of patients in that was still treated with passively scattered proton therapy. And so the studies that came after looked at the use of, increasingly looked at the use of intensity modulated proton therapy. For example, the series from Mayo Clinic describes the acute toxicities and the short-term patient outcomes after IMRT or IMPT for esophageal cancer. It's a small study, but it basically reported similar outcomes as well as similar toxicity in both these cohorts. And also, again, clinically demonstrated that IMPT does show a significant reduction in the dosimetric parameters that the lung and the esophagus, lung and the heart receive. They also reported their quality of life outcomes, and on the basis of the FACT-E questionnaire, there was again a better quality of life in patients who underwent proton radiation compared to X-ray radiation. And this was a slightly larger group where the majority of patients again received concurrent weekly chemo as well. So this is a graph demonstrating that the decline in the FACT-E scores was consistently less for proton patients as compared to photon patients. The Proton Collaborative Group have also published their initial experience with the dose. So this is a multi-institutional cohort. And what is to note is when you compare it with the single institutional studies of the randomized phase 2B arm, this is the proton arm and the IMRT arm, even in a multi-institutional setting, they are able to achieve the same amount of dosimetry, the same kind of dosimetry, and the acute toxicity profile also supports this, that the outcomes seem to be the same in the clinic as when you treat on a clinical trial. So these are the currently ongoing clinical trials for esophageal cancer, and the most exciting of which seems to be the NRG GI 006, which I alluded to earlier. The primary endpoint of this trial is overall survival, and so we do await exciting results from this trial. We also, there is a proposed trial by the European collaborative group called the PROTECT trial, which is a multi-center randomized phase 3 trial. Randomizing patients for preoperative chemoradiation to either proton or photon therapy. And again, they have recently published their treatment planning comparison, and they do emphasize the need for rigorous QA for these patients who are going in with esophageal cancer. So to summarize our experience at APCC so far, we've treated almost 25 patients with gastrointestinal cancer, and esophagus is around 20% of those patients. In the 7 patients that we have treated, as you can see, the majority of patients are middle thoracic tumors. All of them have been squamous cell cancers only, and locally advanced tumors. In these patients, again, we can confidently now say that yes, the dosimetric benefit that we are seeing in all these retrospective and prospective studies, we are also able to demonstrate the same. We have treated 2 patients with preoperative intent, 3 patients with preoperative intent and 4 patients with definitive intent, with varying doses from 50.4 to 59.4 gray equivalent. With a median follow-up, which is short, we have 1 patient who expired due to complications, 1 patient who developed distant metastasis, and the other 5 are alive and free of disease, with very limited toxicity during treatment. And that's, I think, something that we notice in our patients, especially esophageal cancer patients being frail in terms of loss of weight, in terms of their age. These are patients are generally able to tolerate their treatment very well and complete treatment without breaks in chemotherapy or the radiation. So this, to demonstrate, this is a patient who had a weight of around 38 to 39 kilos, 60-year-old lady who presented with a CT3N1 tumor. We treated her with a preoperative intent to 41.4 as per the cross protocol with weekly paclicarbo. And post 6 weeks, proton, she had a partial response on the PET CT and underwent a McEwen's esophagectomy. However, the response was a near complete response. There was a single cell or small group of cells only in the level of the muscularis, and that was why it was a YPT3N0 result for this patient. She remains well currently. This is another patient who has been treated to definitive doses. Again, a middle-aged gentleman who presented with an upper thoracic tumor and who was treated to around 59.4 gray in 33 fractions and continues to be well 2 years post-proton therapy. So in conclusion, I would say that esophageal cancer, proton therapy delivers lower clinically meaningful doses to organs at risk, like the lungs and the heart. This does result in lesser toxicity in the short and medium term. both in the preoperative setting as well as in the definitive setting as the randomized phase 2b trial showed. Most older evidence is with passive scattered proton therapy, but the newer series which are reporting IMPT also confirm similar safety and effectiveness signals. And the randomized trials are eagerly expected, and we await the results of these to provide us finally with level 1 evidence. So thank you for your patient hearing, and I'm open to take questions.
Thank you, Ashwati. It was nice covering some evidence. I just wanted to initiate a question and answer. Do we do adaptive therapy, or is there a requirement of adaptive therapy in esophagus? Means the dilatation, the proximal dilatation, which happens at times, do we need to correct at some point of time in between the treatment?
So we do routinely do almost these 4D, the QACTs every week or so. And so far we haven't had to adapt for dilatation so far. Although I would say the patients that we have treated did not have so much proximal dilatation as we see in certain circumferential cases. But we do that on a routine basis in order to adapt if need be.
Okay. And do you do SIB for the nodes at times?
So we don't do SIB so far. We have done fractionated treatments at 1.8 gray, but I believe that's just us being cautious. We probably can go ahead, but we are currently cautiously optimistic. Yeah.
Great. Any questions?
Yeah. Thank you,
Sir,
Dr. Ashwati.
Yeah.
You finished well in advance, 7 minutes earlier for the floor to have some lot of clarifications. Interesting of your 7 cases which you presented. More interesting in that I felt with a hard mean dose of 5.7 gray. How do you interpret this with our photon therapy, your own, and Dr. Agarwal, your opinion on this? 5.7 is excellent hard mean dose from what I feel.
So definitely that is very rewarding, but I think Dr. Sapna has yet to show you her heart mean doses for the breast cases she treats, so probably that will be even more impressive. But definitely that is something that we that is next to impossible with a photon plan, I believe.
I think Sarah Darby will be the most happiest lady on the globe.
Yes, sir.
Okay. So if there are...
I'll just ask one question. Thank you, Dr. Ashwati, for an excellent talk. I just would like to know, I'm sure that you will be using that 40CT for esophagus because you are using the proton and IMRT. I'm sure you will be using the 40CT for it.
Yes, sir. Yes.
Okay, if that is the case, because the hard dose is being very impactful for the clinical outcome, so what kind of, the 40 phases you chose to evaluate the hard dose? Whether you use MIP or whether you use free breathing or 4D union of, the 40 phases. What kind of phase you use for the evaluation of hard dose? That is most important.
Yeah, so for the most of the esophageal cases, we have used 4D-CT and we assess the motion of the primary, the gross tumor. Most of the cases we have not seen motion more than 5 to 7 mm, which is probably because they are all thoracic tumors. Mid-thoracic is the majority that we have treated. In those cases, we choose to use the average planning CT as the primary planning data set. And we also subsequently evaluate the nominal plan after robust optimization for a 5 mm and 3.5% range uncertainty. We also evaluate that on each phase of the 4D CT.
Okay, because in our experience, though it is a photon based, the 40CT that, the free breathing based, the hard dose will be more or less compared to other, that is what literature also says. You have to evaluate with the free breathing 40CT.
Can I comment on that a little?
Yeah,
Yeah,
please. Yeah, Karthik is our expert in
not expert,
moving
but I will-
tumors. So
I just want to tell you that for esophagus, we generally use 2 posterior obliques. Anyway, we are not going through heart. So whatever you do evaluate in 4D-CT also, the heart doses are in the same range. So we check that also.
great. That's just wanted to share what, we were used to do. That's the reason. That's a really nice, wonderful talk.
thank you, sir.
May I make a point here? Firstly, of course, I'd like to compliment Ashwati for having placed the evidence so nicely, because this is one area where there is convincing level 1 evidence. And also I'd like to thank her for prompting this discussion on the doses that we are able to achieve in left-sided breast cancer with proton. And I'll take an opportunity to mention that for left-sided breast cancer patients with proton therapy, the doses are in the range of 0.9 to 1 gray mean dose. And most importantly, it's also possible to limit the left anterior descending doses, both max as well as mean, to the range of about 3 to 4 gray. Just wanted to mention that. And of course, also thank all of you for being here today.
I just want to thank everybody for the wonderful presentations.
Sir, if I may say, can I add one small point since we have time, 1 minute?
Yes.
Yes, please, go ahead, Srinivas.
Sir, just to add to what Ashwati said about the hard dose in esophagus, I think the MD Anderson group led by Dr. Stephen Lin showed almost 18% in their prospective study, about 18% cardiovascular effects, major acute coronary events, about 18%, grade 3 and above. So in that sense, I think you are absolutely right. This is our personal bias that in middle and lower third esophageal cancer patients would probably benefit, especially in those patients where with conventional therapies, we are delivering excessive doses to the heart.
I think that was very pertinent for the cardiac doses right from the first lecture itself. And I think we will be seeing much more data in the coming years.
Yes.
And we have to be really very cautious about that. And with the awareness all around, we will certainly be able to decrease the doses in future also. Okay, back to Srinivas. Wonderful session. I thoroughly enjoyed it. And I hope with the Dr. Kannan's smile, I think everybody has done the well. Thank you again to all the colleagues at APCC. Back to you, Srinivas, everything.
Thank you, Srinivas.
Thank you very much, Dr. Srinivas and the organizers for the opportunity.
Thank you all the chairpersons. I think it was a very engaging and very entertaining session. We must thank you for your comments and questions and the discussion. So we officially close this session.